Welcome to Navicent Knows Health. I'm Cindy Busby and I'm here today with Dr. Paul Dale. He's a board-certified surgeon and fellowship trained in surgical oncology. And today we're going to talk about breast cancer and treatment options here in Central Georgia. Dr. Dale, thanks so much for being with me.
Thanks for having me.
Would you let our audience know a little bit of an update about IORT? We talked about that the last time we were together. It's a specific type of radiation therapy.
We did. So if a lady catches a cancer early and it's relatively small, then the good news is she has some good options for treatment. And one of those options for treatment is saving the breast. And indeed, in that case, saving the breast is just as safe as a mastectomy. So the lady can then come in, undergo the lump removal, take a lymph node to make sure it hasn't spread, and then after that, classically, she would receive 6 weeks of radiation therapy. And that can either be done here and make it a little closer to home if they travel. Well, about a year ago, a little bit more than a year ago, we introduced the first IORT, intraoperative radiation therapy program in Central Georgia. And since that time, we've treated many ladies, and basically what that allows us to do in these relatively small tumors that are well differentiated, it allows us to take out the tumor, make sure it hasn't spread while they're asleep, to take out the lymph node, and then, if everything looks good, the radiation oncologists, the radiation doctors, come into the operating room, and we put a balloon in the cavity that we made, and we then give them enough radiation that takes the place of 6 weeks post-op radiation therapy. They get that while they're asleep. It takes an additional 8 minutes of the operating room time. It is very well coordinated, and we've had very good success with this technology and technique. And I really think it's a wonderful option for especially our ladies that don't want to travel a lot or couldn't travel. Say, for instance, if you live 50 miles or 75 miles away from a radiation oncology center, you can drive 2,000 to 3,000 miles just getting your radiation in a post-op setting. I mean, it's a lot of driving and a lot of travel. So this, I think, allows more ladies to have breast-conserving therapy, which is wonderful.
When you talk about candidates for that, you talk about well-defined tumors, certain types. Do you find that there are lots of opportunities for women to use or be, successful with IORT, or is it a very specific tumor type?
So since we started the program here, we were very conservative in who we wanted to utilize this on. We're not utilizing it on younger women because younger women do have a longer life expectancy, and we're doing whole breast still in them. But in the ones we're choosing, the ladies that are over 60, the ladies that have smaller tumors, ER/PR positive tumors, we're having very good success. Haven't seen any recurrences, as you'd expect not to, and it's going very, very well. But we are very conservative on who we recommend it to. In fact, some ladies hear about it and say, "I want that," and unfortunately, one thing or another, they can't have it, and they're disappointed, needless to say. But the ones that get it just love it.
How does the partnership with radiation oncology work? Are they certified, or they get trained to do the specific IORT with you in surgery?
Absolutely. So that's a great. So partnership is what we have here at our breast center and at the Peyton Anderson Cancer Center. We strongly encourage this multidisciplinary approach to cancer treatment. And in a multidisciplinary team, you have your surgeons, surgical oncologists, colorectal surgeons. You have your medical oncologists who talk to the patients about chemotherapy after the surgery perhaps. And you have your radiation oncologists who are specializing in just giving the radiation to help reduce the risk of the cancer coming back. So that is our multidisciplinary team. And indeed, when we started this program, I myself and the other doctors that are doing the IORT, putting the balloons in, trained with Dr. Cole and his group, and we all went through the same training and to make sure we was all doing it right and had the right application, et cetera, to be safe. And of course, safety is the #1 priority and concern. And once we were approved, now I can teach the process to other doctors to let them come on board with the team.
When does a woman find out in the course of her treatment whether or not she's a candidate? Is it determined interoperatively? I mean, in the operating room, they may know it's an option, but you're making the determination there.
So they'll know going in that they have what seems to be a small tumor, and they know it's a good tumor, and they've already talked to radiation oncology. So we're all on the same board. And most of the time when that's done, these small tumors have only about a 1 out of 10 chance of spreading to the lymph nodes. And that's probably the biggest risk factor of not being able to do it. If the tumor came back positive, then you need whole breast radiation. But if the lymph node came back positive, you need whole breast radiation. But if the lymph node's negative, most of the time as surgeons, we know going in that we can do a sufficient lumpectomy and get good margins and get adequate skin coverage over that balloon so that you're not burning the skin, because you have to have a certain amount of depth. So we know, and unfortunately, some ladies will come in beforehand and I'll have to tell them, based on your MRI finding or based on my clinical exam, you're not a good candidate for this. Or based on breast size, if it's a small breast, maybe we can't do it. So there are a lot of factors that go into this. It's not just, oh yeah, you can have it done. It's a matter of all of us as a team looking at this and deciding, yes, you're a good candidate.
When thinking about the COVID-19 pandemic, what is the important thing that women should take away about breast cancer screening?
That's a great question, because certainly we may be entering into a new normal, so to speak, and initially the screenings were shut down. We had to stop them, and it wasn't just us, it was recommended nationwide. And that was quite scary to a lot of women, especially those women who had breast cancer. They're like, wait a minute, I know my mammogram is important, I want my mammogram. And I saw a patient just this morning, and a 42-year-old female that needed a mammogram and hadn't had one yet, first mammogram yet, because of COVID. And I said, well, guess what we're going to do? Today's your lucky day, because we're going to do a mammogram. But so it was shut down. And the fear of that is that we're going to see cancers presenting at a later stage in 6 months to a year because of that shutdown. So if you were scheduled during this time, things are back up, things are safe again. We've adjusted times and making sure that everybody stays safe as they go through the mammogram screening process. But it is now safe to get back and get your mammogram scheduled. So if you had to delay, by all means, it's time to go back and go through your screening again. Same with colonoscopies and other things, so that we don't see this huge surge in larger cancers or worse outcomes.
When it comes to getting that mammogram, tell us a little bit about the iCAD that our technologists are now using to help us screen even better for early cancer.
Yeah, it's fantastic. So a few years ago, we moved from what we call digital 2D mammography, which just looks this way, and went to what we call tomosynthesis, which is 3D technology and 3D mammography. And what that does is it screens the breast in slices all the way through, and it allows the radiologist to have a really good in-depth look at the breast. Well, to do that, you have several hundred pictures that are stacked upon one another so that they can slide through that breast. Imagine looking for a raisin in a loaf of bread. If I just x-rayed you this way and this way, I could say, oh yeah, it's there somewhere, but if I could go, I could tell you exactly where it was, and that's the benefit to 3D technology, okay? So when they had 2D technology, there was a special intelligence that you could add to your program, allowing the computer to assist our radiologist in identifying abnormal areas in your mammogram. They have subsequently developed this for 3D mammography, and our radiologists just adapted that and have adopted the new program on in our system now. And what that does, it allows the radiologist to have more have a second set of eyes almost. Even before they look at it, you go through, and I've seen it, it's quite remarkable, and it'll circle areas on the mammogram and say, oh, take an extra look here, take an extra look here. So the radiologist, while looking at the whole thing, this really lets them focus on, well, the iCAD said there's something there, let's look real hard there.
With COVID-19 currently in the community, and potentially in the future, where do you see the virtual visit becoming a large part of your practice or the way that consumers seek medicine?
Yeah, great question. And so before COVID, we had some virtual visits, and certain groups have adopted it, certain professions have adopted it better than others. Surgeons have been a little bit more reluctant to. However, I must say that now, this morning alone, I did 4 virtual visits with patients, some via telephone, some via computer, and the patients are loving it. A lot of it's more in the post-op setting, because as you come in a post-op setting, you're more interested in what was the pathology, and I'm doing fine. I look at you, oh, you're doing great, and you just drove 3 hours or 2 hours or an hour for me to tell you, hey, you're doing great, you look wonderful. So I could tell you that by looking at you over the phone or over the internet. I would love to offer surgical oncology remotely to the smaller cancer centers around the state, allowing them, if they have a patient that comes in there and wants to have a consult with a surgical oncologist, we could do the initial one virtually. There's very few cancers that I can't talk to you about, tell you how we're going to treat it, just based on x-rays and other findings, that we don't have to be in person for me to have that conversation with you. Why not have that initial conversation? This is what we're going to do, this is what things look like on your x-rays, and this is our plan. And I really hope that we can utilize that technology more in the future, and perhaps this is the springboard that we needed.
As we go into October, what would you say to women who are thinking about their first screening, maybe have had a screening but haven't gone back, or maybe have felt a lump? Can you tell them just again how important it is for them to get early screening and treatment?
Well, we know that we're finding cancers earlier. The death rates from breast cancer are slowly going down, and that's due to the fact that we're finding them earlier, and that's wonderful. While the incidence might be going up a little bit, we're finding more cancers because we're getting better screenings, and we're finding them smaller, and therefore finding them smaller improves the overall survival. So that's important. So when you come in and have that first mammogram, don't be surprised if you get that phone call, we see something, can you come back and let us do an ultrasound? Or we need to do this. That's very normal, because that's your first one. There's nothing to compare it to. And very often, almost 9 times out of 10, you're going to come back in, they're going to do that workup, and it's fine. And they're going to say, guess what, everything looks okay, we're probably just going to see you in 6 months and repeat this. It's important to get those mammograms, because without that, you're going to come in with a big lump that you feel. And that changes the tables altogether. It changes your stage and your treatment and options and everything else. So mammography, just like colonoscopy, just like PSA screening for all important. We have cervical cancer. We have all of these screening tests at our availability. We must use them, and that will definitely lower the risk of having dying of cancer, no doubt. Another important thing is if you come into the breast center and we have the option of doing same-day biopsies. So if a lady comes in, they do an ultrasound, oh, you've got a solid nodule. They can actually say, would you like to go ahead and get that biopsy done today? They'll call your physician, get the order, make sure everything's good, and get that done for you. So that alleviates that wait time of, guess what, we'll do your biopsy next week, and then the week after that you get to go see somebody, and blah, blah. So it's speeding that along, and women really like that increased throughput that we're offering. And thanks to our radiologists at the breast center, who are dedicated mammographers, and the ultrasound technicians who do a wonderful job, we're now able to go ahead and get that biopsy oftentimes done the same day. And if the patient says too much, it's going to be done within a couple of days.
Well, thank you so much for being with us today.
Thank you for having us.
And thank you so much for always being such a champion for women's health. We appreciate that.
Thank you. Appreciate it.
Thank you for watching Navicent Knows Health. If you'd like to know more about Dr. Dale and his practice in Central Georgia, please visit us at navicenthealth.org.